All right, wonderful. Jay, I'm going to unmute you here and we'll get going. Have a great evening, everyone.
Good evening. Welcome to today's monthly forum sponsored by Congregation Beth Israel's Men's Club. My name is Jay Berkowitz. I am an officer of the Men's Club. A special thanks to Eileen Tatro, Program Director of Congregation Beth Israel, who's running Zoom. We are privileged to have today as our speaker, Dr. Davey Smith, Head of the Division of Infectious Diseases and Global Public Health at UC San Diego. Dr. Smith is clearly the leading local expert on COVID-19, as evidenced by the frequent references to his opinion in the Union Tribune. This forum is intended to be a Q&A session with Dr. Smith. Many of you submitted questions in advance. These questions were grouped into 3 categories and have been provided to Dr. Smith. The 3 categories are testing, treatment, and vaccine. If time allows, we will open up the forum to additional questions. Dr. Smith's primary research has been figuring out how to stop the transmission of HIV and curing HIV. He has published over 200 scientific publications in these areas. In 2010, Dr. Smith was named HIV Researcher of the Year by the HIV Medical Association, and in 2016, he became the co-director and principal investigator of the San Diego Center for AIDS Research. Since the outbreak of COVID-19, Dr. Smith has been actively engaged in the international effort to find safe and effective treatments. He is the International Protocol Chair for a treatment study, which is part of the US government's Operation Warp Speed. His study is designed to find effective therapies for persons in the early stages of COVID-19. Dr. Smith graduated from East Tennessee State University School of Medicine in 1996. He completed his internship, residency, and chief residency in internal medicine at UC San Diego and stayed to complete his fellowship in infectious diseases. He joined the UC San Diego faculty in 2003 and was promoted to full professor in 2012. In 2017, he was promoted to head of the Division of Infectious Diseases and Global Public Health at UC San Diego. And now, Dr. Davey Smith of UCSD.
Thanks, Jay. Thanks, everybody. I really appreciate you inviting me to give a talk. And just real quickly, this is the commercial. So this is the thing behind me called Rise Above COVID. Please check it out. It's you can just do riseabovecovid.org. It's a clinical trial from Operation Warp Speed that is designed for finding new treatments for early COVID. Oh, thanks for putting there in the chat. And basically, if someone has early COVID, we're trying to find new therapies to keep them out of the hospital. And we're going to talk about one of those that just got emergency use authorization last week, which we were part of. I'm going to go through some questions. I'm also monitoring the chat box, so please feel free to put in a chat there. And I'm going to start off with some testing questions. This is probably the thing that I get asked about the most as of now. But one of the big ones is, what are the available tests and which one is recommended? So there's a whole bunch of tests. There are PCR tests, there are serology tests, there are things called antigen tests. And just to break them down, two of those detect acute infection, and that means active infection, someone who actually has the virus and is contagious and can get sick from it. And those 2 tests are PCR tests and antigen tests, also known as, both of those could be called molecular tests. And those detect active infection. And then the other one is called serology, and that detects antibodies, which we're going to talk a lot about in a minute, and that's to detect old infection. It's not very useful to detecting active infection. So if someone comes in my hospital and they have a cough, shortness of breath, and they had an exposure 5 to 10 days ago, then I'm going to do one of those molecular tests, one of the PCR tests or the antigen tests. If they tell me that they were exposed a long time ago and they maybe had a cough or whatever, and they want to know whether or not that was COVID at that time, then we could run a serology test. The big issue with that serology test is it really doesn't tell me anything about immunity. We're going to talk about a lot of that in a second. It just tells me that perhaps that they had the infection before. Another big question along testing is what is the likelihood of false positives and false negatives? And to be honest, it really depends on the test. Those antigen tests are more likely to have a false negative, while those PCR tests are more likely to have a false positive result. And that means that we have to really understand the population where we're using the test. So if somebody comes in and they're highly symptomatic and we run an antigen test and it's positive, then we pretty much know that they have COVID. If they come in and they don't have any symptoms and they don't have any exposure whatsoever, and we got a PCR test and it is positive, then it's more likely that that's a false positive test. So it requires some work on the part of the doctor and a well-informed patient to know which test to run at what time. And then another question I get a lot is, should I get tested if no symptoms are evident? It depends. It's a really good question. If someone was exposed, let's say 5 to 7 days ago, and they're working in the hospital, they should, or at a nursing home or at a school, they really should be quarantining after their exposure. And then getting a test once they're symptomatic. There are some instances where we would like to get a test on someone who doesn't have any symptoms. To be honest, I would like to test everybody a lot of the time. And then we do that in the lab and in some situations like schools, in certain schools like UCSD at the moment, to basically pick up people before they become symptomatic and then be able to isolate them so that they don't spread it. But to be honest, we just don't have enough testing running around in the country to be able to test a lot of people who are asymptomatic. However, I really hope that we get that figured out soon. And then why does COVID-19 spread so easily? And why is there less concern if outdoors? That's a good question. So respiratory viruses, which is coronavirus that causes COVID-19, is spread mostly by droplets. So when you sneeze, you can think of all those gross little droplets that come out, or if you cough, little bitty droplets, and they go into the air about 6 feet. And in that little zone of 6 feet, when somebody coughs or sneezes or talks loudly, it really can go infect somebody. Now, that being said, there are some instances, let's say people are singing, or there are certain procedures that happen that cause those little droplets to get even smaller and to be able to hang into the air, and that's called aerosolization. That can happen, and that can increase the risk of transmission of the coronavirus. However, that's not the most common way for coronavirus to be spread. It's really spread by the droplets, in which case, really good ventilation in the room or being outside decreases the chance of those droplets to spread very far. A wind picks it up, or the ventilation picks it up, drives it to the ground, or drives it away where it's not infectious anymore, usually to the ground. So that's the reason that outdoor dining is so much safer than indoor dining. And I'm going to stop, and I want to talk a little bit about the current travel advisory along these lines. We are headed into winter. I was on clinical service just recently at the VA, but it's not just the VA, it's all the hospitals in town. We are at the highest number of cases that we have ever been for COVID in San Diego. And the hospitals, the VA anyway, was really full yesterday and is getting fuller. And I am very much worried about what the winter brings. So my cautionary tale along that line is, please be careful, wear your masks, socially distance. And during the holidays, I think it's good if we see each other on Zoom versus in person wherever we can. I know it is super rough. My mom is not happy about me not coming home, but it is better for everyone if we just stay connected via telephone and Zoom. And then I have a question in the chat from Mark, which says, is it better to wear 2 masks than 1? Yes. Well, 2 masks being 1 mask per person. So everybody needs to be wearing a mask. I don't think it matters too much if you were to wear 2 masks, but it really matters whether or not I wear a mask and you wear a mask when we get somewhat close to each other. I wear a mask for you and you wear a mask for me. That's sort of the best way to think about it. But in reality, if I wear a mask, it does decrease the chance of me getting it in general, but it very much decreases the chance of me giving it to you. And then another question that I get a lot is, why are children less susceptible to COVID-19? It's a good question. We are working hard on figuring that out. The best thing that I can tell you now is that children's immune systems are very much what we call naive. They're new. They haven't seen a lot of things in the world, so they haven't adapted to a whole bunch of infectious pathogens. But as we get older, we see more colds, we see more flus, we see more bacterial infections, and it drives our immune response to be a little more jumpy, let's say. So that when we get COVID, the reason that people die of COVID-19 is because the immune system switches from a relatively naive state to a very inflammatory state. And that inflammation can go quite quickly, and then it causes a pneumonia and causes inflammatory cells to go into the lungs and to block up all the airways that we need to breathe. And that's where people get in trouble and need to be a ventilator and stuff. So children just don't have an immune system that is already triggered to be what we call hyperinflammatory, or have that, quote, cytokine storm, which is really just hyperinflammation. And that looks to be very protective for kids, but not so much once you're over the age of 55. Or if you're a man, men have a much worse time with it than women, or if you're heavier. All of those are inflammatory, make people more susceptible to having this hyperinflammation syndrome. Okay, other questions. What items such as mail, groceries, packages are susceptible to the transfer of virus? I don't think any of those are. So there's very little transmission from surfaces, such as going to get the mail, going to get groceries. Well, once you're in the grocery store, that could be a problem because you might be near someone, especially someone who doesn't have a mask. But groceries themselves, if you have them delivered or packages, are really not susceptible to the transfer of virus. I mean, it's always good to wash your hands, but you don't need to disinfect a lot of surfaces. And we're going to talk about vaccines in a second, Rob, but that's a good one. Remind me if I forget. I see that in the chat. And then why are we seeing increases in cases? Well, we know that respiratory viruses always have a worse time in the fall and the winter. In the rest part of the country, that's when people go indoors, and that's just where viruses like to be transmitted, flu, etc. It also turns out that just a little colder weather in the air allows these viruses to live just a little bit longer so that they can then infect the next person. So that is why we're probably seeing increase in cases. The other thing that I think we're seeing an increase in cases is that people are having a fatigue of wearing their mask. We're already seeing people like, I don't want to wear my mask anymore, I'm tired of it. And it's kind of like really hard for me not to say something. And then will at-home test kits be available? Yes, I think today was the day that the FDA approved an at-home COVID kit test. I don't know exactly how much it is, but it is all at home and it's just now approved by the FDA. So I'm going to take a few of these things in the chat. Are there two different types of tests done as blood tests, or are all these nose tests? So good question. Sorry, I should have said that before. So the nose tests are the PCR and the antigen tests, because those detect the active infection. So we find our active infections in the nose and the mouth and the back of the throat. So then when we swab those, we're using a PCR test or an antigen test, and that is detecting active infection. The blood tests are, almost all of those are just to detect serology. So they're detecting antibodies that have developed from the infection. So they're detecting old infections. And then Mark asks, how many viral particles are necessary to initiate an active infection? We have no idea. That is a very good question. We are looking very closely at it. It's probably on the order of about 100,000 copies of the virus, but when somebody has an active infection, they're shedding billions of copies from their nose. And one cough could easily transmit 100,000 or more copies very quickly. And then somebody asked, Shlomo asked, do people with blood type O be more immune? That's a good question. There are some very nice studies from China showing that blood type increases susceptibility, specifically the blood type A, but nobody is immune. Even people with blood type O, they did have a lower rate. People are still looking at that, why that is, what's the rationale, etc. But nobody is immune. Do you use anti-IL-6 for CRS? So we'll go straight into the treatment at the moment. That's a good question. So for the cytokine storm or the hyperinflammation, one of those factors of acute inflammation is caused by a cytokine called IL-6. And very early in the epidemic, including myself, I said that we should really be looking at ways to stop that IL-6 pathway. And there was a drug called Tosulusumab that was tested exactly for that purpose. We know it was useful in other cytokine storm, cytokine release syndromes. And unfortunately, it did not work for COVID-19. So IL-6, anti-IL-6 didn't. Other ones that looked at different parts of the inflammatory pathway, a drug called baricitinib, did show efficacy to decrease inflammation, and it probably will get FDA emergency use authorization soon. Another question was, what early actions can be taken to prevent the hospitalization, prevent the need for hospitalization? That is exactly my trial. So somebody asked that question, and I really appreciate it. But we are looking at different treatments for people to keep them out of the hospital. So they have early COVID, and we want to keep them from leaving the hospital or ventilating or dying. And the first drug that we tested is a monoclonal antibody. It's called bamlanivimab. It just got emergency use authorization. So we finished our phase 2 portion of the trial, and right afterwards, the FDA has granted it emergency use authorization. That doesn't mean that full approval. In fact, the FDA said that you need, you being me, need to continue to do the treatment trials to find the best therapies that are still out there. And this just means that it gives it a little bit more access for people who might have early COVID. So that's one of those antibodies, so monoclonal antibodies. I will talk a little bit about that, and I might bore everybody. But basically what we did for these monoclonal antibodies is that we took people who had coronavirus infection. In fact, this is what my lab did back in March. So we got some people who had coronavirus who were in Miramar. I don't know if you remember that. And on those cruise ships, and they were quarantined here. And we got some blood from some of those people, and some other people who had coronavirus, and we took their blood and figured out who had the most highly active antibodies. And then we were able to pluck their cells that made those antibodies out of their bloodstream, and then we grew those blood cells up to produce antibodies called monoclonal antibodies that we could use as a treatment. But it wasn't just us. It was another 30 some odd companies that did, and academics who did the exact same thing. And those are the ones that are being trialed now in all these different treatment trials. The first one that got the emergency use authorization was Lilly. The company from Eli Lilly had a monoclonal antibody. So that's how that is working. In my trial, we'll continue to look at that monoclonal antibody, but there are others that are coming. And so we should be able to test quite a few to figure out which one is the best one to treat COVID. And then what changed in testing the vaccine for Pfizer? Okay, we're going to talk about Pfizer, and we're going to talk about treatments, vaccines in a second. But let me finish out the treatment questions. What do we know about the treatment and recovery of President Trump? So President Trump got a whole bunch of. So President Trump got a whole bunch of treatments, including monoclonal antibody and Redesvere, which is an antiviral that specifically works on coronavirus. And he got some zinc, and he got some famotidine, which is an H2 blocker, et cetera. And all those were used for the treatment of the president. And what do we know about the treatment and the recovery? Well, he got a big cocktail. Nobody else in the world got that cocktail. The antibody that he got, monoclonal antibody he got, was from Regeneron and not from Lilly. Interestingly, side note, is he was pretty sick sick enough to where he also needed a medication called dexamethasone, which is a steroid. So in general, he got everything. He got the Redesvere, which is a blocker of the virus. He got the monoclonal antibody, which is a blocker of the virus. Then he got dexamethasone, which is a high-powered steroid to stop the inflammation. And then he got a few things that we sort of think might work, like zinc and vitamin D and famotidine. But none of these, except for remdesivir and dexamethasone, had any really good clinical activity at the time that he took it. But thank goodness he recovered. He's doing okay. It seems like he'll be okay from his coronavirus. But that's not the case for everybody. Lots of people continue to have symptoms long after their infection. We could talk a lot more about that if y'all have questions. I have strong opinions. Do you remain contagious following treatment? It depends on the treatment. With dexamethasone, you could be contagious. But in reality, almost all the treatments pretty much decrease your chances of being infectious within a day or two, especially the monoclonal antibodies. They tend to rapidly decrease the amount of virus that someone is shedding. And even the virus that can be detectable is probably not infectious. And then somebody asked, are there any other regular ease the symptoms of COVID? We don't know for sure, but from my patients, a lot of people really say that ibuprofen tends to lessen the fever and fatigue associated with COVID-19. The cough, it doesn't seem like we really have anything that's great for the cough or the shortness of breath. Okay, let me just make sure I have all the treatment questions. That is my shtick, so I'm hoping. Just wanted to really talk a little bit more about a few other ones. So the first one that was highly touted was hydroxychloroquine, including me. I thought that we should test it. The problem because we did see that it had efficacy in the lab, we could see that the virus very well with hydroxychloroquine. And it was a cheap, very readily available, pretty safe drug. It just became very quickly politicized. And the trials that were eventually started at the NIH for hydroxychloroquine were really started too late and then had too much political baggage to really be continued. If we were to ever use it, we would have used it in early COVID and not in the hospital. The problem was that doctors were using it in the hospital in really sick people that it probably made them even sicker, and it wasn't ever really going to work in that setting anyway. What we don't know is if it would ever work during early COVID, and perhaps it would. It's just there's no way that the science could go forward with too much politics going on. So we pivoted with the NIH and said, we'll just go try these other drugs that are made specifically for coronavirus. That's how these monoclonal antibodies happened. And then the other drug, remdesivir, it can only be used in the hospital because it requires multiple infusions, IV. And it's probably not as potent, but we'll see. More clinical trials are on its way. And then someone has a question of, is there a role for oxygen saturation monitoring in persons who are COVID and have no or minimal symptoms? Yes, so one of the things about COVID is it decreases the ability of oxygen to get into the blood. So we monitor, in the trial, we monitor oxygen saturations in the blood and see whether or not the treatments that we're using actually improves that oxygen saturation or not. So in a clinical trial setting, it works great. In a regular setting, like we have a COVID clinic now, follow them on closely. We don't think that it's that useful. It's better to probably go with someone's symptoms because some people have low oxygen levels, even if they don't have COVID, sometimes randomly during the day. And we notice that causes a lot of anxiety in people and would start going to the emergency room, et cetera, when in fact they were pretty well. It's really about their symptoms of feeling short of breath and walking upstairs, et cetera, that is more alarming than just having a test that says that they have a low oxygen saturation. I don't know if that is Dr. Gass, my former attending at the VA. So he is. I hope I'm doing okay. And then vaccines. Let's talk a little bit about vaccines. So how do vaccines work? Good question. So vaccines, like pretty much any vaccine that we have these days, flu, measles, hepatitis B, hepatitis A, yellow fever, it basically is a way to get your immune system to look at a new pathogen, build an immune response to that pathogen, and then hopefully when you're really exposed to the pathogen, you don't get the infection anymore. That's the vast majority of our vaccines. So you can think of a flu shot, you give a little bit of the pieces of the flu, not the real flu. You can't get the flu from the flu shot, but you give little pieces of the flu and the immune system goes along, looks at those little pieces and goes, oh, I need to figure out how to fight that infection. And then when you do get exposed to the real flu, the immune system has a leg up and can then direct an immune response to it. And that's exactly what we're trying to do with these COVID vaccines. Now, an issue with that is we don't know what part of the immune system is most protective for COVID. It could be antibodies, that's the classic one, but we have other parts of the immune system like T cells and what we call innate immune cells, such as natural killer cells, or even those cytokines. Those are macrophages and monocytes, etc. They release interferons and other cytokines that protect us from various viral infections such as COVID. So there's this whole mix, what we call the immune milieu, that can protect us or not. We are working very hard to figure out which part of the immune system is most important for protecting people from COVID, because once we know that, then we can direct our vaccines to be a little smarter to pick up what we call the immune correlate. What exact part of the immune system protects somebody from coronavirus? But at the moment, that is not what we're doing. We're doing exactly kind of what we're doing with the flu vaccine, is that we take pieces of the virus and give it to the immune system to look at to start building. Is a genetic material that makes a protein. So you inject this little bit of nucleic acid into the muscle. The muscle then helps turn that mRNA, read that mRNA into protein. So that mRNA is like a code, and it tells the body to make this protein. And the protein that it makes is a part of the virus called the spike protein. And that's usually the first protein that the immune system would see in a regular infection. So it builds an immune response to that spike protein, both antibody and T cells, and B cells are the ones that make the antibodies, and then T cells make it what we call a cellular immune response, and macrophages and natural killer, etc. And they all come together to craft an immune response. The great news is that both of those vaccines had greater than 90% efficacy for preventing infection. That is absolutely great. Better than what I ever thought would work for those vaccines. The FDA said they would be willing to approve a vaccine if it only worked 50% of the time. So we're doing much better. So I am very hopeful. So that's the good news. The bad news is coronavirus, as we've known for a long time, you can get the same one every year. So even after you've gotten the regular infection, your immune system has fought off that infection successfully, it still can get infected again from the virus. So the problem is that the immune system doesn't have as good a memory for coronaviruses as it does for other things like measles or yellow fever or hepatitis B. So the question now is, can a vaccine do better than the regular infection? And we know also with COVID-2, this novel coronavirus, that people also can get infected with it more than once. We're only in this pandemic not quite a year, definitely not a year within the United States, and we're already seeing people who've gotten this virus more than once. So their first infection wasn't enough to protect, didn't train their immune system enough to protect them again so many months later. So I don't know. The Pfizer vaccine looks great. The Moderna vaccine looks great for some protection. It's just how long does that protection last? We just uploaded a paper showing that antibodies seem to last a very long time after somebody's initially infection. So we're hoping that it's just a rare group of people who lose their immune response over time. Now, what that means practically is that we might need to get vaccinated more than once a year for this virus, or maybe every year, depends on what the next generation of vaccines look like. But that is something undergoing research at the moment. Let me just see. Somebody put in, Mark said, neutralizing antibody titers are 5 times above what we have seen in patients. Could this give a better memory response? Yes, neutralizing antibody seems to last for a long time, and that's something we're very much looking at and can be quite high in some people. Some people don't mount a very good neutralizing antibody response. We don't know if that's still leaves them open to infection or not. And then somebody asked, why are some people worried about the mRNA vaccines? Are they right to be concerned? So some people, this is Rob, so some people are worried about mRNA vaccines because we've never used this vaccine platform before. Well, that's not true. We've used it, we just haven't had an approved vaccine for this platform before. We have lots and lots and lots of experience of using egg-based vaccines or other live attenuated vaccines like measles for decades, right? But we don't have a lot of experience with this mRNA vaccine. It's just a new platform, and people are always a little skeptical about new platforms, especially when they're messing with our immune system. I'm less concerned, but I do think that we need to do our due diligence and look very closely at how this is going to hurt or help our immune system over time. And then somebody wrote, I hear that a virus can adjust itself to vaccines and become back in a slightly different form that is immune to the present vaccine. First, is that true? And second, how much worse will the next one be? It is absolutely true. The flu vaccine is a classic one. The flu mutates every year, and that the vaccine that you get one year might not work the second year. There's 2 reasons why that is. One, the flu mutates, so it changes its nucleic code to be able to change its proteins to evade immune responses. So we gotta get another flu vaccine. The other one is, when I get my flu vaccine, my immune system loses its memory by the time the next year. So it needs a booster to remind itself what it needs to really fight off. So both those things happen at the same time. Now, the good news is the coronavirus does not mutate as much as the flu virus, but it does mutate, and that was, the big concern of why they killed all those minks over in Denmark, I think, is that there was some back and forth transmission between the minks and the humans, and there was definitely mutations going on, and people worried about how that might affect vaccine efficacy. I don't know, but definitely the virus can mutate, especially going back and forth from different species. And then somebody asked, if you were the governor of California, I don't want to do that. What guidelines would you put in place? So we do lots of, we have had discussions with health departments, including in the governor's office and at schools. I think, this is being recorded, right? It's going to come back to haunt me if I ever run for office, but no, it's true. I am very, very worried about the next 2 months, maybe the next 3 months. And I would try to shut down as much as I can for 2 weeks. If we could really shut down for 2 weeks, get everybody to wear masks, stay at home, etc., unless you're essential. We've seen it over and over and over again. We can really drive the case rate down. The virus is only out there and around for about 2 weeks. And if it does drive it down, then we can hold it at bay. The problem is we are on the upswing and not the downswing. So any little bit of opening up or defying of public health guidelines is only going to make everything absolutely worse. So if I had a magic wand and I know this is not popular, I would really lock things down for at least 2 weeks to get this under control. And then Stephanie asks a good question. How big is the coronavirus genetic drift? This is the change of the mutations over time. The virus just drifts along in its mutations. And how big is it? The coronavirus, the good news is the coronavirus genetic drift is not that large. There's very little difference between what we see now in the coronavirus and what we saw back in December of last year from the China one. Just a few mutations, and in the big scheme of things for an RNA virus, which a coronavirus is, it's very small. Just to put this into perspective, everybody who has the coronavirus vaccine, that virus looks basically the same. I mean, you sequence in it, it looks almost identical. But for someone who has HIV, if you have two people who have HIV, that virus could be 5% different in its genetic code and still be the same virus. So the genetic changes that happen in coronavirus are much smaller than what we see with other RNA viruses like HIV or hepatitis C. Why has COVID not reappeared in China? COVID reappeared in China, and it has a few times, and it depends on where you're looking. But it's also, we're a little concerned that they're not as reporting it as much as they were. They've done much better, honestly, in lockdowns. So they do, when they see an outbreak, they really shut it down, which saves lives. And then Mark said, the mRNA platform enables rapid evolution of the vaccine by just... That's a good question. People have talked about that, that you can have an evolving vaccine. Even more interesting is this thing called trans-interfering particles, or TIPS, that can actually evolve along with the virus. And those are being tested with my friend Lior Weinberger up at UCSF, and we're going to be trying to get that vaccine and that treatment down to test soon for COVID. So try to use evolution to our advantage in these. When can we expect to be approved for distribution of a vaccine in California? Soon. I think that once the safety data are all in, both for the Pfizer vaccine and the Moderna vaccine, I expect to see some emergency use authorizations and the vaccines to come out. I don't think the Moderna has any vaccines on the shelf to be able to be given out, but Pfizer does. I think they have 50 million doses. That's not a lot. Honestly, there's 350 million people in the country. So we're going to have to figure out how to ration that vaccine. And there's lots of discussion going on right now. Do we vaccinate people who are, quote, super spreaders? Or do we vaccinate people who are the most risk for getting very ill from the infection? So super spreaders are usually young people, say those college kids or even high school kids, who are more likely to transmit the virus and to bring it home. From a modeling aspect and an infectious disease aspect in terms of spread, you definitely want to hit the younger group and to prevent the infections from getting out in the community to begin with. From an infectious disease standpoint and a physician, I want to protect the people who are most vulnerable, which would be the people who are older and more likely to die of the infection. So those discussions are going on now. I'm pretty sure that we're going to be vaccinating the people who are most vulnerable. But probably the first ones also are the frontline workers, so people who work in the emergency rooms or police or ambulance drivers, EMS people. I think those would probably be the ones getting it first. Can a state block or delay distribution once the vaccine receives FDA approval? Yes. There are some states that are already sort of whining about that. I don't know exactly what's going on, but there's lots of politics around vaccine delivery to some of the states, and you could probably guess which ones those are. Okay. I think I got all the questions, but Jay, I don't know if you saw, or Marty, did you see any that I missed?
Can I just read some of these?
Yeah.
Will multiple vaccine options be available? How do you choose the best vaccine, and who gets to choose?
Yeah, that's a very good question. There will be multiple vaccine options available, I think. So right now there's the AstraZeneca vaccine, the Janssen vaccine, the J&J vaccine. All those are still being tested in part of Operation Warp Speed. We have 2 of those trials going on right now at UCSD, the AstraZeneca and the Janssen. They work by a different way called a viral vector. So they use another virus to deliver the proteins of the coronavirus to stimulate the immune system. They are very, very stimulatory to the immune system. I have some concerns with some of them, but all of that will be tested within the trial program. Then, during those trials, we'll know better who should get which vaccine. Perhaps you could use a very immune stimulatory vaccine for a younger person so that you could beef up their immune system to prevent them from getting infection and spreading it, and worry less about the about the risks of that vaccine in that young person versus giving it to an older person who might be more susceptible to those greater risks. I don't know which one is which at the moment, but that's exactly what the clinical trials are supposed to do. What else you got?
Do we know how long the various vaccines remain effective? Is there any sense of that? Can you get, well, you answered this. Go ahead.
No, it's a great question. We could talk about that all night. I don't know. We don't really know how long these vaccines will last. In these trials, it's only for a short time. So 2-3 months show this 90% efficacy, which is great. And I think it's going to last for a pretty good while, but I don't know exactly how long it's going to last. But hopefully these trials tell us how long it's going to last, and then we can plan accordingly for how long do we need to get a booster, and then we need to know if the booster even works. All that sort of stuff still has to be worked out in science. I mean, I guess my biggest plug here is that how to get out of a pandemic is through science. And we just really need to support those scientific trials.
Yeah, we had another question that was skipped. Should we be concerned about vaccine side effects?
Yeah, so should we be concerned about vaccine side effects? Yes, I think that there are some vaccines that might be have more side effects than others. It looks like the mRNA vaccines, they're just now reporting out their safety data, but it looks to be relatively non-toxic, pretty benign. But the other vaccines that use those other viral vectors seem to have more of a risky factor to them. They also tend to be more immunogenic, so it tends to be a better immune response, but whether or not there's safety attached to them or not still has to be determined in those trials. So I'm going to be looking at that closely.
Yeah, we had three more vaccine advanced questions. I'll go through those. How quickly can the vaccine be distributed, especially in view of any special handling requirements?
Oh yeah, so both the, good question. So one, the Pfizer vaccine requires it to be at -80 centigrade. So RNA, these are RNA vaccines, so they're not that stable. So you need to freeze them very quickly and keep them frozen. And the Pfizer one requires very, very, very cold temperatures. So lots more than your freezer at home. Requires liquid nitrogen, etc. And that's going to be a big problem in getting it out to all the places across the world. And even in the United States, it's going to be very difficult. Most hospitals have a liquid nitrogen, but definitely not all pharmacies and definitely not all doctors' offices. So that's going to be a major issue. The Moderna vaccine has a big leg up on that. They only require -20, which is still a lot colder than your freezer at home in most doctor's offices and most pharmacies and most places where people get their vaccines don't have that sort of capacity. And we've been talking a lot at the state and national level on how to increase the capacity for keeping what we call a cold chain, keeping everything frozen until we can get it into somebody. And that's going to be a big hurdle. Hopefully these other vaccines, well, I know those other vaccines don't require that same level of cold handling, but we'll see how useful they are.
Okay, the next two questions relate to people wanting to see how long it's going to take for this to be over. The first question was, what needs to happen before we return to the old normal? And at what point in the vaccination of the population will masks no longer be recommended?
Oh yeah, I remember those questions at the end. I didn't scroll down far enough. So yes, so what happens before we return to the old normal? Oh, I feel horrible about having to give this answer. I don't think we're ever going to return to the old normal. I think that we're always going to have to be very diligent for this coronavirus. It will be throughout my career, I'll see people with COVID-19 come into the hospital. And there's a bunch of reasons for that. I don't think we're going to have enough vaccination across the world to be able to prevent this coronavirus from constantly circulating. And the other one is I don't think we'll ever fully be able to do the masking and social distancing for a long time enough to get the virus out of the population in general. So the virus is always going to be popping up and hiding out and popping up and hiding out. And so the new normal is going to be, I don't think we're having a new normal. The new normal is going to be masks and social distancing, etc. But the good news is I think with the vaccines and the treatments, we are going to return to some sort of normal, but we're going to just be more cautious than before. At what point in the vaccination, the population will masks no longer be recommended? So I will give the number. The number is if you have a 90% effective vaccine and your virus, so this, what we call a reproductive rate for a virus, is for every one person who gets infected, it infects 4 other people. So for the population to get rid of this virus, you would need 3/4 of the population to be protected. So 3 out of the 4. And that's either through vaccination or masking and social distancing. And right now we already know that 20 to 50% of the population in the US wouldn't take a vaccine even if it was available. So that means we'll never get to that, quote, herd immunity, even if a vaccine protects for a long time and it was as effective as it looks like it's going to be. There was also a question on bradykinin. I don't want to. So does SARS-CoV-2 cause a bradykinin storm? Yes, to explain the thrombophytic effects of the infection. Yeah, I'm pretty much sure that that's the way that this virus is working. So this virus is funny. It's a little sneaky. It stimulates this immune response, this inflammatory response, and for a long time we know that inflammation also leads to blood clotting. And then early in this epidemic, we noticed that that's how it was killing people. It wasn't just a pneumonia and keeping people from breathing, it was also causing blood clots that went to the heart, like a heart attack, or to the brain, like a stroke, or to the lungs, which we call pulmonary embolus. Those were also killing people too. And now we see it in young people that it causes little bitty clots that form in the heart, and that causes myocarditis. And it's probably through the bradykinin pathway. There's a few papers that look like that's the pathway. Now people are looking at how to manipulate that immune response, that bradykinin pathway, to hopefully decrease that, decrease that problem that happens with this virus. Every year, many people get a flu shot. Will we need some sort of COVID shot yearly? I think that's probably the way that's headed. It depends on how long these vaccines last. And should we be concerned about the vaccine side effects? I think we need to look at that closely, but it's going to be, we'll figure that out in the trials. These trials are big enough and they just need to be followed for long enough to figure out what the safety problems are. Were enough people tested to warn us about this? I don't think we still don't have enough testing. Testing is a foundation of almost every public health thing we do in all these epidemics. You could think of TB, flu, the first SARS seniors, I like to say. All of those testing becomes so important. It's basically to know thy enemy. And once you know them, then you can isolate and quarantine and contact trace, etc. We just don't have enough testing. Even now we're having these huge surges, and we have much more testing than we had back in July and August, when was the last time we had a big surge. We have much more testing now, but we still do not have enough testing to be able to do the contact tracing that's necessary to do the quarantine. You see anything else in there, Marty?
I was thinking about the shot, and I can never remember the name of it, that they were giving in the 1950s, that they were convinced was going to be helpful, but in Britain, it ended up causing deformed babies. And that's my concern with this vaccination with regards to side effects. Did they do enough testing of the vaccination to determine how safe it is to avoid that kind of side effect?
Yeah, so
Formaldehyde, yes. Arnie
Yeah,
got
I think Dr. Gath put in there thalidomide. So yeah, so that's an interesting one because it was given to mothers who had morning sickness, but then it was the babies of their babies, the babies of their female babies. So let me just be really clear. These things that we do in terms of drugs and vaccines, etc., could have really long consequences. And we are only 10, 11 months into this epidemic worldwide or in the United States. So really, we're doing things very quickly. We're doing them the best we can, but the long-term outcomes are just not going to be there for a long time. Yeah, it worries me that there might be side effects. People ask me, will I get a vaccine? Absolutely. I'm going to get a vaccine. I think that the data look that the risks, that the benefits outweigh the risks, and as long as it's done in a careful way, and then I can hopefully contribute to science along the way and measure if there's any out bad effects, then yeah, I think that's the only way we're going to be able to do it.
How many patients are there in the UCSD COVID clinic?
You mean like on a daily basis? Because we saw 12 today.
Okay, so you yourself saw 12.
No, one of my colleagues saw 12. I'm on an inpatient service at the moment.
Okay, and how many of them are having a cytokine storm?
So none of those in the COVID clinic, because those are all outpatient. The ones that I saw in the hospital they all had a cytokine storm.
And what are you giving patients with cytokine storm?
Mostly we know that supportive care is the best. It is the best way to get out of it. We are much better at people living than they were before. At the beginning of the epidemic, we were learned, and now we know how to treat it. But if they require oxygen, then we give them Redesvere. If they start to get really inflamed, then we give them dexamethasone.
What is your take on the Remdesivir trials? The WHO was claiming that wasn't so great.
Yeah, so that's a good question. So Remdesivir is an antiviral that, so it works on the actual virus. It is only used in the inpatient side when someone's very inflamed. So both trials were done inpatient, the WHO and the randomized controlled trials in the United States for the most part. The ones in the United States showed some efficacy. It wasn't what I would call a blockbuster in the US. And then the ones that were done in the WHO was not randomized or blinded, showed absolutely no effect. So what that tells me is there's probably some effect, it's just not big, right? It's not a game changer in my opinion. You're probably going to do just about as well if you got it or you didn't get it, but maybe just a little bit better if you did get it, and just a little bit better than that if you get it early. The problem with it is the only way to get it is in the hospital. So getting it early is not feasible.
How about the methotrexate? I mean, that seems to only be a 30% benefit.
Yeah, dexamethasone, I'm not the biggest fan of that, but it did show survival benefit, probably around 30%. The reason I'm not the biggest fan of it is that the trial that it was in was in the UK, and there they had a huge mortality rate in the unit. So in our intensive care units in the United States, someone goes in the unit probably has a 10 to 20% chance of dying, which is horrible. But in the UK, it was close to 50%. So it really wasn't the same patient populations as we see in the United States. So what that tells me is that they gave their dexamethasone to really, really, really sick people, and perhaps even sicker than the ones that we see in the US. I know that I'm getting into the weeds, and I apologize for that, but I just wanted to give you my thinking.
Are there other cytokine storm patients that could benefit from additional therapies, or are they all on a clinical trial at this moment at UCSD?
At this moment, they're all on a clinical trial. Well, we have dexamethasone and Remdesivir outside of the clinical trial, but we do have other clinical trials going on. One of those drugs being a JAK-STAT inhibitor called baricitinib that showed efficacy. And then there's others that are like it that are coming along the way.
We've got
You're
just a few,
basically-
sorry, Joel, sorry. We have just a few minutes left. And I do see another question that came through the chat. So we can still stay on a few minutes at the end, but I do want to make sure we get through our time and I can end the recording. So Shlomo had a question, and then I also want to make sure Marty has everything wrapped up on his end as well.
Sure. So Shlomo asked a question about R0 of around 5 to 7. So this virus somehow, it's either somewhere between 4 to 8. It's a big number. But for every one person who gets infected, how many other people that it spreads to? So if it's around 5.7 or 6 people, then you need to vaccinate 5 out of every 6 people to get to the herd immunity. And then I also see another question about incidence and types of long-term consequences from Paul. We don't have the best handle in terms of long-term consequences because we're not really long-term into this infection. But this long hauler syndrome seems to be somewhere between 5 and 15% of people who get infected and have disease. So they're symptomatic at the time that they have acute infection. So they have COVID-19. 5 to 15% of them will go on to have very long-term symptoms. And those symptoms are usually fatigue, brain fog, which is memory concentrations, concentration problems, and muscle aches. And sometimes they have intermittent fever, but that seems to be rare. What is some good news that, go ahead. Oh.
Can I ask a quick question? I'm very curious about something. So vaccination gives rise to an IgG response, and the virus enters through the nasal cavity, which is mucosal infection. And mucosal immunity is through an IgA response. So can you envision the world getting immunized with the vaccine having an IgG response and people still carrying the virus in their nasal cavity because they don't have an IgA response to fight off the virus?
Yeah, so that's a good question. So IgA is stuck on the mucosal membranes, and that's what we use mostly to clear out viruses from our membranes. But IgG also can clear virus. So if the virus cannot get through the mucous membrane to start an active infection that persists, it will go away on its own. So I'm not worried about the vaccine only tailoring to an IgG to keep it from being eliminated in like what we call nasal carriage. Viruses don't usually do that in general. But the other part is a really good question is people are now starting to think, well, maybe we need an IgA vaccine. And in fact, one of the things we're working with now at UCSD is to turn little bacteria into vaccines themselves. So it'd be a vaccine that has a spike protein, a bacteria that has a spike protein in its plasmid. We drink the bacteria, it lives in our gut, and it stimulates an immune response in our gut, which is IgA and Th helper, and that hopefully will be something that can clear mucosal membranes. So people are thinking about it because you were exactly right. We're not exactly targeting with an IgG.
Okay, great, thanks.
Can I just ask an everyday question, something not quite
Sure.
so just for my own knowledge. So assuming we can get a vaccine, whether it's January, February, March, once you have that vaccine, you will still need to wear a mask, you will still need to social distance. Is that what I was hearing you say?
Yeah, so let's say the vaccine works 90% of the time, and you're one of those 1 in 10 people. And especially if you're vulnerable for getting sick with the infection, then you need to wear your mask. Or if you were a young person who is more likely to spread it to lots of people if you were to get it, then we would really like you to be wearing your mask because we know that the spreading of that virus from young people is super important. So if even with a vaccine, 1 in 10 chance of someone to be able to get it and spread it, we still need them to wear masks. That's a bummer, huh?
Yeah.
Sorry.
Yeah, I was hoping it would be, like the polio vaccine where you get it and at least for that period of time, you really wouldn't have to worry.
Yeah, I think we'll get, to be honest, so somebody asked, can I give any good news to share? So I think we'll get there. I think we'll adapt. Humans are good at adapting ourselves, and we'll adapt to a new normal in terms of we should never have shaken hands. We should never be kissing on the cheeks when we greet people. Those are just really bad ideas for infectious diseases. We should probably bow. I think they do it right in Asian countries. But we're probably going to have to get used to masks in certain areas and socially distancing and getting better ventilations in schools in places where we do congregate, and then understanding how transmissions happen and be able to do better at testing and contact tracing and just understanding how those these viral pandemics work to keep us all safe.
Just one more quick point. If that is the case, a lot of organizations are going to have to totally rethink how they operate. So performing arts organizations, I mean, from what I'm hearing you saying, you know, you're not going to go back to a theater and be sitting next to people in a theater. So it has ramifications for so many organizations and the way we have lived for so many years. It's really somewhat overwhelming when you think about it.
You know, it is. I also think that there's human ingenuity there, because I see there's a company right now that's developing a test that's very cheap where you would blow into a tube and it would test for coronavirus. So you could think of, let's say I want to go see the latest Avengers movie, that we'd all just spend $2 more to get that breath test before we go in to see the movie. And if that test is negative, we go. If it's positive, then we go get referred for contact tracing or, you know, a confirmatory test. So I think those are some of the big structural changes that that's gonna need science and technology to get us out of it.
Wow, so much great information. This was fantastic. I do want to pass it over to Marty. Again, like I mentioned, I know there were some very deep specific questions, and if Dr. Smith can stay on for a few minutes after, we can chat about those, but I do want to close the general portion of the lecture. I'll pass it over to Marty Stern.
Thank you very much. I have a whole bunch of thank yous that I'll try to make as quick as I possibly can. First, I want to thank Dr. Davey Smith for a marvelous program. This was incredibly informative, and I particularly appreciated the fact that I was able to understand most of it, because I'm not a doctor. I'm as layman can be, so I deeply appreciated this. I also want to thank Eileen Tatra, the program director at Congregation Beth Israel. This and other programs at Beth Israel, you can thank her for, because she's the one that runs the Zoom. She's the one that records this. She's the one that often sets a lot of these things up. She is marvelous, and I deeply thank her from the bottom of my heart. I also thank Jay Berkowitz, who is the point man for the men's club from Congregation Beth Israel. He is the one that arranges all of these speaker forums that we do once a month, and he finds the speakers and arranges the entire situation. Finally, I want to thank the audience. This was a very, very good audience. I deeply appreciate it. Keep in mind, audience, this is brought to you by the Men's Club of Beth Israel. We get most of our funding through donations, not from your dues, so please keep that in mind. Once again, Dr. Davey Smith, thank you very, very much for a marvelous program.